All right, so we're going to quickly review urinary, endocrine, and mental health disorders as well. And then we'll talk a little bit about the reproductive system too. So uh, we didn't do urinary yet, right? Or did we? All right, so I just want to tackle a couple things just to make sure we're all on the same page with going back to urinary. The big thing, nephron is the functional unit of the kidney. That's what filters blood and turns it into the byproducts into urine. The pathway for urine from the kidney, ureter, bladder, and then urethra to exit. I thought for us in the physical therapy, well, for any of the rehabs, the neurogenic bladder is making sure we understand that's because of a spinal cord injury. It's not actually a bladder or incontinent loss of control thing. It's because of it's the neurological origin of that loss of control. Digestion starting in the mouth, that's a lot of mechanical breakdown. And then stomach, more breakdown as well. The small intestine is what most digestion and absorption takes place. Gallbladder stalls bile. And we can tell when someone has a gallbladder issue when they intake fats, then the bile needs to release. And if it can't, then usually that's what increases pain and discomfort with digestion on that. Um, Endocrine, I think the big thing to remember with endocrine is hyper or hypo. So endocrine, certain diseases are either going to cause the endocrine system to go into overdrive, or it's going to cause it to be hyper slow, as a hypo. Um, so I have Cushing's as hyper adrenalism, too much cortisol, Addison's too little. Graves' disease, hyperthyroidism. The Graves' disease, man, that's one of those you should be able to spot from a mile away. What's the key physical feature? What is it? The eyes, right? The bulging of the eyes. That's when I when I looked at the bill after taking my kids to Disney over, I was holy cow! I had a acute Graves' disease for a moment. Um, And then a few different types of, diabetes is so important for all of us in rehab. I don't care what it is to understand. Type 1 diabetes, insulin dependent, diabetes insipidus, low ADH, which increases urine, so not necessarily blood sugar. That's a weird one. The diabetic coma occurs when we have too high of blood sugar, insulin shock too low. And then what would our steps be if we think their blood sugar is too high? It's our emergency steps. You guys just done with the semester already? When they were so if they have insulin on hand, then yes, administering or having them administer insulin. Um, but also that's a 911 event. So and then what about insulin shock? So too low of blood sugar. Give them sugar, right? So and that's one thing that so that's one thing we constantly talk about. If our patient has diabetes, we need to know where's the sugar. And if it's in our clinic, we should have sugar on hand, either glucose tabs or juices in the fridge. Or if it's their home, then we've got to make sure they have adequate quick sugars for us for that. The mental health, what are some thoughts about the mental health content that we looked at? Was there anything that stood out to you? I don't know why I ask you guys questions. You're basically not here today. I think some of the things, hallucinations are a false sensory experience. There's a lot of different hallucinations. They could be auditory, visual, even tactile. Oh my God, bugs are calling on me, but there's no bugs. So that's something to understand. But delusion is a false belief. I think the most common the extreme examples is I believe I'm God and I mean, I've got a healthy ego of myself, but it falls just short of that. But that's where those delusions come in. I think one of the tough things about a lot of the mental health side of things, where especially anxiety, having a diagnosis and also having a feeling can be really sloppy and tough to have a conversation with. And I can remember a lot of patients, me asking them, like, oh, are you anxious about this? And they like completely become defensive. I don't have anxiety. And it's like, oh, no, no, just a feeling I'm talking about. Are you nervous about going for a walk for the first time on your painful knee? So I think that's part of what is really complicated with mental health because are we talking about a diagnosis or a feeling and being able to tease those out? Um, but some of the disorders, bipolar, the mania versus depressive states, um, anxiety is that fear affecting function. And again, anxiety is the example I have of yes, anxiety is a medical diagnosis that has lots of different treatment options to it, but anxiety is also feelings, right? So our patients being nervous when we check their range of motion for the first time after rotator cuff repair, it's a feeling, and we'll work with that. And I think that's something we get really good at working with. Um, and the paranoid personality, distrustful, suspicious type activities or behaviors. Um, and with the thing that we have to do in the rehab world is make sure we're adjusting our approach to the person. And we do that automatically already. But when we add these mental health conditions, whether it's just a feeling or an actual diagnosis, so let's think bipolar, right? So let's do the manic episodes of bipolar. How do you think you would change your treatments? How would you adjust your treatments when someone's in that more manic of a state?
Increase them.
Increase them, maybe. What else? What other ideas do you guys have?
Do things that can like help them get grounded, like slower movements potentially.
Yeah, I think that's probably the direction I would lean into. So having a quieter environment, having a slower pace with everything, instead of feeding into that manic hyperdrive sense like world, let's do the opposite. Let's go into a quiet area. Let's turn down the lights. Let's quiet this environment around to help try to bring them back down a little bit. Did you have something, Christian?
What do you do the same with like high mode? They're like really happy all the time. So I don't go to extremes.
Yeah. Well, let's talk. So it's so funny the different shapes that manic episode can take a form of. Yeah, and sometimes it's just a great day and they're fine and we don't need to adjust anything. Other times we do. And I'm thinking more of the manic, unable to concentrate, not focusing on the task that we need to get done together. That's where we would use some of these. Let's slow everything down to try to reel them in. Not everything needs an intervention. We don't have to fix everything. And especially with the mental health concerns, it's not our world. It's outside of our scope of practice, but it's going to impact our world. And how are we going to let that happen? What about the more depressive episodes, whether it's, depression, or in this bipolar, we have those depressive episodes as well. What do you think we could do? Tell me more what you mean by concentrate on the more. Okay. Yep.
Walking.
Yeah, so they're going to need their hand held a little bit more when they're in that depressive episode. It's good. What else? Yeah.
Trying to think of this one, like, ask, like, try to work with them, see, like, what types of things that are important.
I love that thought. So the response was, asking them, what do you want to accomplish today? Yeah, and having them, giving them some flexibility and some power to on over there. I think that's a fantastic approach. One of the other things I always do is maybe Ashley can confirm this for me. I hate inpatient, whether it's hospitals or this happens especially at skilled nurse facilities, where the patients, don't want to go anywhere, don't want to get out of bed, they're in pain, haven't slept in 3 days, food sucks, whatever. Um, I hate when the lights are off, the shades are drawn, the room is dark, and then we come in saying, "Hey, do you want to exercise?" No, we don't want to exercise, right? So the first thing I always do is I open up the shades. We're getting some light in here. Let's go. I always wear bright colored shirts when I do my home care. I am coming in with abundant energy in both my physical presentation, like we are ready to go. We're here. We're going to accomplish something together today. And hopefully that brings them just enough that they can participate in what we need. But can we do things if we were planning on doing things in the PT gym? Can we make an adequate session just in their room? Yeah, yeah, yeah. And especially if we pull the shades open, now maybe after 5 minutes of doing some basic stuff and having the environment reflect that it's time to be awake now, maybe that'll be just enough to get us to have something a little bit more beneficial accomplished in one of our sessions.
I have a question.
Yeah.
I can't tell if overthinking it or if it's valid, but like it ethically is like bribing a patient who's really low. Like to say, like, here, if you get on the spin bike and do 15 minutes, which is like shorter than what we had planned, then the next 15 minutes we can like do some massage for your sore shoulder. Like, is that a good way to get them motivated to get some endorphins, or is that kind of like manipulative?
I think so. The question was like bribing and use of rewards to get them to participate in what we want.
What might help them to like feel better?
Yeah, 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 yeah. No, I think I'm not opposed to it.
Yeah.
And I think the power, as long as the decision always lies in the patient, then we get them on board with whatever we've got. Um,
They're just presented as an idea of what we could.
yeah, yeah, yeah. And I mean, I don't love rewards and punishments as a baseline. But I can remember one time I had this patient, she would show up late every single, she was the last appointment on Friday afternoon, and she would show up late every time and demand a full. I said, I'm out of here at 5. You show up at 4:30. You show up on time and we can do ultrasound, but you show up late, that's the first thing I'm cutting out. So if you like it, show up on time. If you don't, I know these other things are going to help you more than ultrasound will. So I think there's some common ground that we're finding. I don't necessarily consider that a bribe or a reward or a punishment either. It's just here's the reality. We need to get these 3 things done. Let's get these 2 things done, and then at the end we'll do the fun thing or the yeah. I think that is acceptable. And yeah, 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 yeah. So that's a good question though. All right. Do we have any other questions on these 3 topics, GI, urinary, or mental health? Yeah. What do we got?
The follow-up in that kind of pressure state, would it be more beneficial? Because I know that there's some patients, at least an outpatient, that will show up whether you want them to or not. They'll be 30 minutes early for the first time of the day. And then there's others that like, it's like really trying to like, getting them there is a extremely difficult thing. So it would be like calling them, making sure that they're coming to the appointment and like being able to reschedule them quickly if they aren't canceling, because I know actually dragging them in is it can be very difficult.
Yeah, and I think some of the concepts that we've talked about is the phrase that I keep hearing is meeting them where they're at, right? So if they have great difficulty getting to the clinic, they're always going to be 30 minutes late because emotionally it's difficult just to get out of bed. And some of the strategies that your business would employ to work with that person is going to vary business to business. I know some practices that say uh, we'll turn you away if you're late. We're going to turn you away, which would really suck for that person. I finally got here, now you're turning me away. Charging them either late fees or missed visit fees is a part of it. Some businesses are very strict on that, others are less. So I was working with a patient. I was done with her. We were going to transition outpatient PT. She called the place that she went to previously, and they said, "Oh, well, you have a $25 missed visit fee remaining on your account, so we'll have to take care of that before we start this episode here." She goes, "I'm never going to you again. You take your $25 bill and you shove it wherever you want." And there's plenty of other places out there. So I think from a business perspective, there's a lot of negotiate that. Um, can you make them your last visit of the day so it doesn't affect other patients? And you can, now it's your time that you're adjusting. Make them the first visit of the day. Like there's ways to do that. Um, you know, book them during your lunch, and then when you're done with lunch, they're ready to go for you. There's some ways that you can navigate that. That has to just be okay with you and the business that is supporting you. And that's there's more factors to it than just what would we do for that person. I always think, and I think everybody in this room would be, find a way to help this person within the complexities of their life is what I think we all on paper would do. Um, how we try to achieve that would vary greatly with the person, your schedule, and the business that we're all in those rules for. So I don't have a perfect answer for you for that. Any other questions or comments about this mental health section? All right. All right. So we have our cumulative final next week, right? So you do have a study guide for this. It's in the worksheets tab. It's all the way at the bottom, the final exam study guide. It is just a guide. It's just a way, it's not 100% inclusive, but it is meant to help you make sure if you can understand that stuff, then you've got a good foundation to then go off on your own for. Just quickly, I was just glancing at some stuff. Sign versus symptom. And that's one of those things that we use oftentimes in clinical practice. We use them interchangeably, but they are two different things. Anybody can break down sign versus symptom?
Sign is what you can see, symptoms what a patient.
Yeah, and objective versus subjective is probably another way to put it, right? Sign is objective. I can measure it. I can do this. I can touch it. I can feel it. I can measure it. Symptom is the experience of it. Yeah, yep. And sometimes the reason why a lot of times they're clumped together is because sometimes they're both, right? So the rating of perceived dyspnea, I feel out of breath, and also I can measure your respiratory rate or your rating of perceived dyspnea. So that's why sometimes they're used interchangeably, but they are two different things. I think cancer, the malignant versus benign was a big one. Malignant spreads, benign does not. But just because something's benign doesn't mean it's not life threatening, especially if it's in low space places like in your brain. Um, that could cause significant problems. What else did I write down? Anytime that there's something that says this is the most common type of cancer. This is the most common type of, like, you will always need to know the most common stuff, always. You will also always need to know the contraindications, precautions for this diagnosis. Do not do this. That will always show up on any exam for either in your schooling or your licensure exam, whichever version you're taking, massage, PTA, or OTA, all of those, like it will always show up. Those are just core safety things. Integumentary, the visual examination is the number one diagnostic tool that our dermatologists use, is the visual. The different types of fractures I thought were important, and important for us to understand. What's the only fracture that only kids get, or I should say most of the time? Green stick, right? So that's the green stick fracture. In our neuro section, multiple sclerosis, the myelin sheath is being destroyed, and that's what the big reason for that is. Spina bifida is a developmental defect in that neural tube and utero. Polio, viral infection causing that. I think it was COPD, the difference between pink puffers and blue bloaters are the big ones to make sure we understand about that. With our cardiovascular, I thought the blood flow and electrical current and how that is in the heart, I thought that anatomy knowledge was really important. I think, and other than that, the other sections we already covered. So. All right, and then lastly, the reproductive stuff that we talked about. What did you find interesting about the reproductive system? Nothing. You liked the mental health one more than the. Oh man, I think about her all the time. Yeah, that was if you didn't watch the video, the mental health, we will be able to catch things because one, we're working with our patients and we can pick up on things, especially personality changes. And the two most important questions that I was taught that I used that day when it was just that lady said something that caught my attention, and it wasn't as obvious as I want to harm myself, but she said something. I said, "Wait, say that again." And that's when I use those two important questions. Do you want to hurt yourself, and do you have a plan? And if they say yes to either one of those, then we've got a call right away. And then, I mean, she answered both, and she knew exactly what she was going to do. She had her plan, and I can't blame her. She had a terminal, quickly progressing brain disorder. So, yeah, it was really really powerful to sit there, and I canceled the rest of my day. I no longer have anything else to do. Called the husband. I'm not leaving until you get here. And please come back now because I'm not just gonna. I do have other things I'm trying to do, but wherever you are, just finish up and come on over. I don't know if I forget if I told in that story after I left, he was grocery shopping. He came home right away. I told him what was happening, called the doc, and then I said, "Okay, you got it from here. I'll see you guys next week, but I'll talk to the doc, and if something changes and you need to move me around, let me know." And then he went back out to finish his grocery shopping, and then she took a bunch of things. Yeah, yeah. Yeah, yeah. It was just like, what did we just talk about, man? But it's easy to get really mad at that guy and say, how could you do, what did you just heard what the problem was? But he also was all of a sudden a caretaker for his wife who has now an advanced disability. He's trying to do everything. He dropped his stuff at the grocery store to come right home, and he was like, but now we don't have potatoes and we got to eat. Like, and I'll be right back. Yeah, yeah. And yeah, really unfortunate situation for everybody involved. Yeah. But we're gonna, we will catch that. And I think there are probably more opportunities for me to catch it that I just haven't yet. Being in practice for 17 years now, that was the major one that I caught. And there were probably others that I missed that I just didn't catch or didn't broach those conversations. Just with the volume of people we work with, we're going to catch it to some degree. So, yeah, it's conversations. No, none of them are fun to have, but they're really important. And all you have to do is just be the right person at the right time to say that again. You seem a little off today. Everything all right? And you might pick up on that. Uh, all right. Yeah. Thanks for bringing that up. Reproductive health. Anything else reproductive health that you thought was interesting?
I
What?
thought the analogy that you used for the pelvic floor acts as a sling for everything in the pelvis.
Yeah.
I've
Yeah.
never heard it described that way. That's like 100%. That's exactly what it is.
Yeah, yeah, it's just a muscular sling that holds all those abdominal content, all the organs and all that. Yeah, that's all it is. Yes, we need to strengthen that up as much as we can. Um, so anybody here interested in pelvic floor, more women's health than men's health? Chris is shaking his head, going, "No way, I'm above the waist only kind of a guy." Yeah, some people are, and one of the things, and it doesn't matter if you don't want to do it. So for Christian and other people like Christian, then that's okay. We don't have to be an aquatic specialist to know which patients would benefit from aquatics. So, and we should all be able to have an intelligent conversation with anybody that might need aquatics, right? Listen, I'm not the person to help you. I don't do aquatics, but you're the type of person that would benefit from it, and I can find you an expert. That's the exact same approach. At minimum, we should be able to have about pelvic floor and reproductive health. So, muscles, I think we talked about this before. Muscles, don't think about the pelvic floor, any muscle. What are the problems that can happen with the muscle? There's two problems. That's it. Too weak. What's the other one?
Spasms?
Oh, okay, yeah, and that's the category I was looking for is too tight, and whether that's because of a range of motion deficit or kind of a neuromuscular deficit like a spasm. But yeah, the muscles are either going to be too weak or too tight. Pelvic floor is just a bunch of muscles. Their problems are either going to be too weak, which we talked about a little bit with, especially with incontinence, on a few different ways we could do it. Kegels with pelvic floor exercises, using the bladder and using how much water are we retaining as the progressive resistive exercise, because when the bladder fills, that sling of the pelvic floor now has more weight on it. So there's a bunch of strengthening stuff that we could do. We also talked about different weights, both in sizes and the weight itself of different devices that can be inserted into someone to help strengthen the pelvic floor that way. Those are all up for grabs for us as well. All right, now, so we've talked about that already. There's also a big problem when muscles are too tight. They can cause pain and dysfunction, and especially for our patients with pelvic floor, either spasm or just physical tightness. Um, the impact on sexual intimacy is really impactful, and it affects relationships and affects far greater than, my pecs are tight and I don't stand up tall enough. Like the other, and how it trickles into relationships and then mental health outside of that is profound. So even if we're not the experts to treat someone, I can have intelligent conversations right now to design a great program. That's not from that. I don't possess that knowledge. But what I hope I can do is if I catch one of those problems, I hope I can have an intelligent conversation and give them hope that there are people out there that can help you, and I can help find those people for you. Um, and I hope we can champion our patients, men or women, because it can happen to both. But that we can champion them, that they can actually improve upon this. And I think that's something that's changed quite a bit over the last, I don't know, decade and a half or so, where before there was there were, yeah, one main pelvic floor physical therapist in Rhode Island. Now there's a bunch more. I think we've done a lot better job. But for some of our patients, it's not fun to talk about and rather embarrassing for some of them. And we need to be okay having those embarrassing conversations and just being, I'm so thankful you're comfortable enough with me to start talking about some of this stuff. And there's a path that we can make improvements. So, um, you know, even if we don't want to be the practitioner of choice for these issues, being able to have a conversation to guide our patients at best is at minimum what we have to do. Uh, so, any other questions or comments about the reproductive system? Yeah.
I was gonna say, I like how, like, in terms of, like pregnancy, I was recognizing.
Yeah, and yeah, the physical and hormonal changes after pregnancy for women are profound. It is another day in the office. There are drastic things that change. And then also just musculoskeletally, the changes that the female body goes through. If any of us, what's the average number of poundage gained in a pregnancy? 35 pounds, I think was the average. Do I have that right? So 35 pounds if any of us gain 35 pounds and a few men that are in here, gaining 35 pounds in less than 9 months, how would your body feel? 35 pounds, and that's a lot all at once, right?
Depends on what the weight's made of.
Um, so yeah, just the mass changes. And the real gains happen really in just the second and third trimester, first trimester. So it's really like 35 pounds in 6 months. So could you imagine gaining 30 pounds before you come back in the fall? That would be nuts, right? And how much aches and pains that would cause. Now, to make things even worse for you women, it's all centralized. It's all just in the anterior portion of your abdomen. Well, that's going to change your body kinematics, your center of mass. Like it is drastic how it changes. And then you have the baby, and man, there's 10 pounds out right away, and then a couple more over the next few days with fluid loss. And holy cow, that like you lose it like that too, which now it's a huge other pendulum going the other way. It is drastic what the female body goes through during pregnancy, from a musculoskeletal standpoint, but also that emotional and hormonal standpoint too. It's drastic. Yep. Any other comments or things you thought was interesting that for reproductive health? All right. Any questions on anything for Patho? Stop this here.